Good morning, everybody. Thank you so much for joining us today for the prevention and management of behavioral expressions in dementia. This presentation is brought to you through Alzheimer's Orange County in collaboration with Silverado. I'm going to make sure everybody is muted. And if you have a question throughout the presentation, please feel free to jump off mute and ask to our presenters. They're more than happy to answer questions as we move along, or you can put your questions into the chat box and we will work our way through that throughout the presentation. So to introduce our two presenters, we have Ashi Gill, who is a healthcare professional dedicated to enhancing the lives of seniors with cognitive impairment. Currently furthering her education at UCLA, she began her career as a dentist before transitioning into healthcare operations, earning a master's in healthcare administration. As an administrator at Silverado, she is committing to upholding its mission of providing innovative and compassionate dementia care. Her work focuses on creating a supportive environment for residents while guiding their families through the journey of cognitive decline. Inspired by a deep connection to her grandparents, she is passionate about making a meaningful impact in senior living. Outside of her work, she enjoys traveling, beach outings, and spending time with her families and Great Pyrenees. Kim Boutram joined Silverado in 2014, bringing 30 years of extensive experience, leadership, and clinical expertise in serving and treating those with neurodegenerative disorders. As part of her role, Kim oversees Silverado's university affiliations, as well as any of the studies in which the company participates. With a strong background in Alzheimer's and dementia research, Kim is committed to harnessing the clinical expertise at Silverado to ensure that results from the latest studies are put into practice. Kim also works with the nursing teams to analyze and develop best practices based on Silverado's evidence-based clinical outcomes, which have been collected over the past 25 years. So with all of that said, I will now hand it over to Ashi and Kim.
Wonderful. Thank you so much for the introduction, Lauren. And good morning, everyone. Thank you so much for joining us. And I know I can speak on behalf of Kim that this is truly your passion. So any questions, anything that you guys have during our presentation or afterwards, we'd be happy to address and answer and share our experiences in memory care as well. So today's session focuses on one of the most misunderstood aspects of dementia, and that is behavioral expression. So what is behavioral expressions? Behavioral expressions in dementia are often misunderstood. They're not random, they're not purposeless. They're meaningful responses to internal or external stimuli. These behaviors, and Lauren, if you wanted to turn the slide for me, please. Thank you so much. These behaviors such as agitation, wandering, delusions, pacing, verbal and physical aggressions are often the only way a person can communicate unmet needs. Rather than managing or suppressing them, our goal should also be to decode them, to ask, what is this person trying to tell us? How can we best support? Don't assume a behavioral expression is because of one's dementia. Lauren, next slide, please. Thank you. This is one of the most common but harmful assumptions in memory care. We often fall into the trap of attributing every behavior to dementia itself. But research has consistently shown us that behavioral expressions are often caused by unmet needs, discomfort, pain. And it's important as dementia care leaders that our first response should always be curiosity and not control. What is the why behind this behavior? Only then can we come up with an intervention or a management plan or an action plan that works with compassion and effectiveness. And what is being communicated? Behavior is communication, and all behavioral expressions should be seen as a form of communication. These behaviors can present itself in different ways. The person is trying to present an unmet need with fear, with physical discomfort, with physical pain. And we've seen signs of that at Silverado Brea or other Silverado communities as well. When a resident is wearing a shoe in the wrong foot, that causes discomfort. That causes them to be agitated, as we would be. Brief is soiled or irritated. Old injury flaring up. I have a resident who every time he gets up from a chair, when he moved in, he would pat his knee. And later on, when we were curious and spoke with the family, turns out he's had knee pain his entire life. So we got him on pain management. So it's important not to just assume that this is a normal symptom of dementia. It's important to be curious. Hunger, emotional pain, overstimulation or understimulation. A behavioral expression can occur because the person is frightened, frustrated, in pain, or being triggered by the environment. Pam, did you have anything else that you wanted to speak for behaviors?
I would only add boredom. We see a lot,
Yeah,
right? And that's why
absolutely.
at Silverado Brea and our communities, we do cognitively appropriate. We do different clubs. So someone who is more impaired can feel successful in their club,
Absolutely.
and someone that's in our brain health program is adequately stimulated, because boredom is a huge trigger for behavioral expressions too.
Absolutely. And one of the things I will add, we utilize different tools to be able to map these communication. And Lauren, if you'll go to the next slide for me, please. One of the tools that we use to figure out what this communication of need is, and something we have found to show great success, are behavior mapping. Our next slide will show a little bit more depth of what behavior mapping looks like and what is being communicated. Behavior mapping is a tool that we utilize in Silverado, and it tracks three things: A, B, C, antecedent, behavior, and consequence. This helps us utilize the tool to identify patterns, to identify trends. Is a resident upset because they don't like the music in the evening? Are they sundowning? We identify the root cause behind all of these behaviors that are happening, and behavior mapping allows us to do that. And behavior mapping is a tool that our caregivers and nurses, and honestly any associate, can utilize. Every 30 minutes, we write down what our resident is doing, where they're at, what is agitating them, what is the trigger behind it. This helps us identify what we need to work on as their providers, as their advocates. And that has been very fruitful in our dementia diagnosis and our treatment plan as well. Kim, is there anything else that you wanted to speak on behavior mapping?
I would only add, in any setting, I think that's a great tool. It doesn't have to be like, let's say a doctor gives you a new medication. It can
Yeah.
often be tough to realize, did it make a difference or not?
Mm-hmm.
Example, even the antipsychotics that many providers give people living at home and things like that, if they're having agitation, they're only modestly effective. So even doing your own course of behavior mapping, try to figure out, because when you're back reporting to the doctor, did it make a difference or not? Then
Mm-hmm.
you'll know if it really did, because it's easy to just think in the last day, does it seem like it's a hard day or not? And you really want to identify it, because if the medications aren't working, then you want to be able to say, no, they're not. Every extra medication increases risk of fall by 7%. So you want to really be able to track, is a new medication, let's say you're assuming the agitation is due to a urinary infection. Okay, they got treated. Does that, after treatment, do you see the behaviors better, or is it continuing to seem to be triggered, or has it responded? So this looking at antecedents, so what occurs before the behavior and could be triggering it, then the behavior, and then looking at the consequence, right? Because sometimes someone might be bored, and if they get yell out, man, they might get somebody's attention, and that's a great consequence. So you have to look at if you're doing anything that could be reinforcing the behavior.
Absolutely. And I will add to that as well. What we have noticed in our communities, it's a great tool to show our families and have those intentional conversations about, hey, the resident really doesn't need antipsychotics. They need pain management, like Kim was referencing to. So it helps us become curious, but has something tangible that we can discuss together as their care providers, and also for the families, because we all work in conjunction to advocate and partner for our residents and for our families. And apart from behavior mapping, we'll go next slide, Lauren, is further evaluation. While we're looking for triggers and consequences to the behavior expression through behavior mapping, one of the important things we need to consider is a possible medical cause. Like Kim mentioned earlier, is there a urinary tract infection, constipation, tooth pain? These conditions cannot always be expressed with words, so it's important that we identify it for them. And those can sometimes manifest in agitation, in yelling out, in screaming, looking for attention. Medical evaluation must always be part of our behavioral assessment as well. And some of the possible medical issues are in the next slide that we will talk about. So urinary tract infection, constipation or GI symptoms, arthritis, like the resident I was telling you guys about earlier, when they would get up, they would have this, they would scream, they would yell out, but they weren't able to communicate that they had knee pain, fingernail or toenail problems, oral or tooth pain, exhaustion. We have, a resident who, when he first moved in, would not sleep through the night, and that caused him to be very agitated in the morning. So it's important to be able to identify and rule that out as well. And headache. Undiagnosed medical issues are a frequent source of behavioral expressions. And studies have found that 70% of behavioral expressions in long term can be linked to physical or medical cause. Presume pain, presume discomfort, and then evaluate it thoroughly.
And I would add, Ashi, sometimes the things that, we all know that seem little, and we work with our nurses in educating them about, you can get a small skin tear or an ingrown toenail, and people can think it's not a big deal, and you don't see. And so to your point, especially as, more providers don't really lay hands on people anymore. Right. So you really do something we encourage and ask our clinical leaders to do is do a real assessment of, yes, they're nurses, but let's try pressing on their abdomen to see if they've got constipation. Let's take off their shoes and make sure we've looked at the toenails, and that can be done at home. So if you have a new behavior, it's vital that, as Ashi has said so well, that you're curious about what could be a potential cause.
Absolutely. And once we have ruled out possible medical issues with the entire care team, with your primary physician, with yourself, we go on to environmental causes. And what are the possible environmental that could be causing these behavior expressions? Lauren, if we go on to the next slide, the environment for a resident matters deeply. Changes in routine, noise levels, or even lighting can increase confusion and agitation. A new caregiver, an unfamiliar face, may feel threatening to someone with an impaired memory. Our physical voice, our tone of voice, our daily flow must all be tailored to promote calm and predictability for our residents. It's important, even if we feel like they don't recognize us or they don't recognize their environment, they do. They recognize the environment. They recognize to a certain degree where their room is. So as much familiarity as we can bring and instill into their daily lives, that has shown to be very, very positive for them. And there are certain interventions that we put into place. So once we've ruled out possible medical issues, possible environmental causes, it's important that we realize what we can do from a preventative standpoint. And if we go to our next slide, it talks about prevention. So we'll go on during this presentation and talk about what those interventions look like, because we don't want to be reactive. We want to be proactive. We want to be preventative. And some ways to do that is robust evidence-based education, music therapy, purposeful engagement, caregiver education. These are not just strategies, they are acts of dignity that we do for our resident. Every time we prevent an escalation through early intervention, we preserve trust and quality of life for our resident. We go on to our first topic for intervention, and I think it's really, really crucial, is caregiver education and support. Training is transformative, and we truly believe that. Research has shown time and time again that staff, when they receive, or providers and caregivers, when they receive dementia-specific education, behavior incidents can drop as much as 40%. Trained caregivers feel more confident. They feel more connected to be able to make decisions, because they have to make significant decisions throughout the day. So we want to instill confidence in them, in our caregivers. And at Silverado, our training is ongoing, it's hands-on, where all of our 100% of our associates, whether they're frontline or not, are dementia care certified. And it is important that they know how to validate our residents' feeling, how to redirect them as needed, how to be able to connect with them as needed, because that is truly what will make them successful. And going on to validation. Validation is not passive listening. It is actively affirming a person's emotional reality. It is listening carefully to the feelings that they are feeling. For example, I have a resident who had a very close relationship with her sister, who has since then passed away. It is important to listen to her and understand that relationship, hear about it, validate what she's feeling. It's important if she feels like, I have a resident who's been a nurse for 45 years, and almost every day she comes to my office and gives me a nurse's report. And I never tell her that I'm not a nurse and I don't understand any of these clinical terminologies. But I always validate. I take the shift report from her and it helps calm her down. It gives her a sense of purpose and it validates her feelings. And that is really important that we do that. We respond by acknowledging that need before we redirect our resident. So validation is definitely our first step. Going on to our next step after validation is redirection. We redirect to something personally meaningful to their resident, whether it's music that they enjoy listening to, a snack, a photo album, about their past, if they liked nursing school or how they cared for their loved ones, or law school and things of that nature, something that brings them comfort, their loved ones, their families, their kids, their grandkids. This is really important. These moments ground our residents in reality and in joy. So it's important that we redirect them to things that are very meaningful and very intentional for them.
Ashi, can I just add, because I
Yes,
think
please.
redirection is a term that not everyone completely understands.
Of course.
Sometimes we'll visit in another community or maybe another setting, and people will be saying to someone who's trying to get out the door, get away from the door, get away from the door, come over here. That's not redirection. And so it's really important, as Ashi has mentioned, the piece of validating first. What is the person trying to express? And so, as an example, often in our communities, our receptionists, that's why they've gone through the dementia certification, understand, and we all have individualized preferences and are well known about what are the things we can redirect each individual resident with. But as an example, it might be, well, that person, it's morning and she typically thinks that she's going to meet someone in the morning or her daughter. And so acknowledging, oh, I understand you're ready for your daughter and she's not going to be here right in the next few minutes. So let's go ahead and get ready for her. Let's come in here. And, you have to validate the anxiety over thinking she's missing an appointment with her daughter before you can redirect her. And so the validation to redirection is so important. And I would say something we often see when we get new associates from another setting is the question of, because not every place, and that's why I think it's so important, and for family members to understand too, because many families struggle with the idea of redirection. It's very hard when your loved one looks just like they look throughout their entire life, and you see they haven't had a stroke, they don't look like they're weak on a side, you can't tell that they're struggling with some cognitive impairment, and have realistic expectations, right? You firmly believe, often as a spouse, well, if he tried harder. When I was in a clinical practice, I would often hear, if they tried harder, they could remember, or no, he's doing this to be difficult. And so you always, and so we, rather than orienting the reality to Ashi's point of the acknowledging the emotional communication with validation and then redirecting them to something that they're interested in and that's individualized to their needs. I think an important, interesting point about redirection is what we have in our communities, right, Ashi? And that's your memory boxes. So in our communities, we have very large memory boxes, and sometimes we'll have families say, oh no, he won't know if there's anything in it or not. And we have to say, oh, absolutely he will. And it's a great redirection tool of, oh my goodness, you won this award, or you love ballet. And we'll ask family members to bring their interests and things to help as redirection tools. So individualized redirection is a very strong non-pharmacological method to deal with behavioral expressions.
Absolutely. And thank you, Kim. I have been in senior living industry for about 5 to 6 years, but redirection I learned when I arrived at Silverado and I saw how proficient everyone was. And it definitely takes a minute to understand how important it is for our residents to be redirected in a way that is calm, that is kind, and that protects their dignity and also validates their feelings at the same time. We will have certain residents who are, in their opinion, getting late for a doctor's appointment, or they have an important client to meet. So being able to tell them, hey, your bus is, a little bit late, or things of that nature, and bringing them to something which they enjoy, like our memory boxes, like our art clubs, those things are so effective and are non-pharmacological tools that we utilize at the community level that have shown to be very successful. And going on to, and I know we touched on it earlier, is purposeful active engagement. It is important that our residents are taking part in activities that are well suited to where they are. We meet the residents where they are on their cognitive level. So idle time is the enemy of well-being in dementia care. Purposeful activities restore meaning and prevent agitation, though they prevent those behavioral expressions from occurring in the first place. And activities tailored to cognitive levels boost confidence. They reduce behavioral incidents. And that is what our 3 levels of club do at Silverado. It ensures that every resident is engaged at the right level, that they are involved in it. They don't get bored because it doesn't challenge them enough, but at the same time, it's not too challenging. So it's appropriate that we have them be part of these active, purposeful engagements where they are going to find the most success at. I will add, every picture that you see on this presentation is from Silverado community. So these are the engagements and the activities that we do at our community and find great pride in, and something our residents truly love and enjoy as well.
I
One
think
of the
it's a
other
good point about in terms of engagement too, right, Ashi?
Mhm.
You have many success stories, and I know it's more than we can share here,
Yes,
but of people who were in other environments and they said, oh, their behavior is horrible, right? That
yes,
they thought they needed lots of medications and they come to Silverado, and yes, we're all about appropriate meds. It's not that we don't use meds.
of course.
What we'll often see is just giving someone an open environment and giving them the dignity of something that engages them in meaning and purpose is huge. It's not passive watching TV, right? That's where people get up and disrupt the groups. But if they're actively engaged and feel like they're making a difference, I mean, I think all the hours, the volunteer hours that our residents have done outside of our community, right? The first year they did more than 8,000 hours of volunteers, and that's what, even if you're living with a memory impairing disease, you have a need to make a difference. And I think, I've heard sometimes when I was in clinical practice about people feeling like, do they have no expectations of them anymore? There is a need for purposeful making a difference in the world all the way through end of life.
Yeah, absolutely. And like everything that we do, it's very individualized when it comes to our engagement. And I know we have too many success stories to share, but I'll share a really quick one. We had a resident that moved into our community that was just not finding success anywhere else. And through curiosity and discovery, we found out she loves gardening. And we right away made her a standing garden. She actually used to come to my office a lot, and I have a lot of plants. And she very smartly noticed that all of my plants are dying, and I do not have a green thumb, and she needs to come to my rescue. So right away, she goes into the garden. She's like, well, you cannot be at my garden, but I will make it happen. And she now has a beautiful flower arrangement in that garden house. So it's important that we're validating their feelings, we're engaging them in activities and hobbies that they have always enjoyed doing, but might not have found it in the last few years of their dementia diagnosis. So re-engaging them is really, really important to us, and individualizing their engagements is important to us as well. One of the other things that our residents really enjoy is music, and music therapy is profoundly effective. Evidence has shown that it is the music that our residents listen to from the ages of 10 to 25 that has the potential to calm them. It has a potential to be very preventative when it comes to behavioral expressions. Our residents here love Elvis. We always have Elvis music playing in the background, and they love to sit there and listen and reminisce. And again, like that said, music should be individualized to one's interest and what they listen to at that age. We have a lot of events that we do where music therapists come in and perform. We have a lot of our residents who were great musicians themselves, who like to sing, who like to play the guitar, and we highly encourage that in our setting. Anything which connects them to what they enjoy is a success for us. Pet therapy. These are actually all pets here at the community right now at Silverado Brea. And like we all know, pets offer unconditional love and they offer unconditional presence. A calm and gentle dog can reduce anxiety and even physiological symptoms. I mean, studies have shown repeatedly that pet therapy lowers cortisol, it increases oxytocin, and it decreases agitation. It's not just soothing, it's very science-backed, and it's a great tool for redirection as well when they're having a behavioral expression, to redirect them to a love of a pet that they truly enjoy. So not only is it preventative, it can also help redirect them when they're having a behavioral expression. And selfishly, we also love having them at the community as staff. So it's a win for everyone present. Foods and snacks as well. Snacks are more than a treat. This is a charcuterie board we actually made for our residents a couple of months ago. I'll show you guys a couple of slides down why. But their snacks are more than treats. They're comfort for them. They're a great distractor. We have a resident who truly enjoys chocolate. So everywhere in our community, we have staff that have chocolate. So if she is, not feeling the best that day, or if she needs to be redirected, we have chocolates, and the family notices and truly value that it's individualized in that way. And of course, for the resident, it's great. And a familiar food can do more than that. It can ground a resident and offer a positive reinforcement tool. It's a small gesture that speaks volumes in care.
I think a good point about food that I would just add, our clinical staff knows that often if someone's a little hesitant to maybe get in a shower, or there's nothing like giving them an ice cream sandwich or a chocolate kiss to unwrap, while they're doing that. So to your point about the distracting, it's great. And I think the other thing that we see great success with at Silverado is the fact that our residents have the option at any time to go to the kitchen bistro refrigerator, right? And help themselves to a snack. And I always joke, I know that my husband, when he needs memory care, is going to stand in front of that refrigerator for hours because he currently does it, right? But that's part of our normalization, treating our residents just like someone without a dementia, secure.
Exactly.
But having, many people want that ability, and that helps with what can occur in a dementia in terms of weight loss, that access to food. So it's a win-win across the board.
Absolutely. Absolutely. Moving forward, we're going to talk about stimulation, and more specifically overstimulation and understimulation, because it's important that we find the right balance for it. It's important that the right level of engagement with the right pacing in a setting that is safe and comfortable and calm for a resident. So again, we don't want our residents to be bored. We want them to be actively engaged. If they like gardening, having them do a gardening club. But at the same time, if they are more of a resident who are in their sensory neighborhood, or might not find that successful, we have different clubs and different activities and engagements that they will find successful, like our sound baths that we do, our pet therapy that we do. Those things are very important to identify and have our residents be in the right and appropriate neighborhood where they'll find the most amount of success at. Overstimulation as well, too much noise, activity, or too many choices can lead to behavioral expression because the person can feel overwhelmed. So we want to challenge them, but we don't want to overwhelm them. And it's really important to be able to identify it appropriately. Okay. Tolerating behavioral expressions. Not all behaviors need fixing. If a resident is rocking, if they're humming or pacing, and it's not harming them or others, it's okay to let it be. Our discomfort should not drive intervention. Respecting autonomy is at the core of ethical dementia care and at the core of what we do at Silverado with normalization. So often one will want the behavioral expression to stop. However, if the person's behavior is not harmful, it's important that we respect their autonomy as well.
I think a great story around this one, Ashi, is one of the residents that I think moved into Brea, that it came from a different setting that she was in, and the community found it very, very difficult and wanted her to move. And we weren't sure why. And when we asked, they said, well, it's because she moves the furniture all around. And our answer, it was exactly, so when she leaves the room, do you move the furniture back? And so that tolerating things that we have to learn to what's important, what kind of behavior would put someone at risk or another person at risk, or is it just, to your point, just deal with it in other ways. Something that can happen sometimes is when people may shop or help themselves to something that belongs to someone else, and eventually they'll set it down, and then you can put it back in that person's room. So there's a toleration that doesn't escalate behavioral expressions, as Ashi has mentioned, and it's very important if you're working in dementia care to understand that.
Absolutely. That's a great point. And we see a lot of that as well, right? It's everyone is different, and their autonomy is so important, and it's important for them to find freedom in as many ways as they possibly can. And tolerating behavioral expression is one of the freedoms that they have, and prevents those behavioral expressions from exceeding or getting too far. So as much freedom, as much autonomy as we can give our residents, the better it is for them. And communication techniques is one of the other interventions that we have. When we go to the next slide, we'll talk about how important it is to be clear in our communication, calm and consistent. So explaining what is done. I'll give you an example of it. It is really important when our caregiver is providing care to our resident to explain what they're doing. It's important to say hello, introduce yourself. Hi, Mr. Smith. My name is Ashi, and I will be changing your shirt because it has something on it. Break it down into each step, break it down and simplify it as much as possible so that they know what they're doing. And I always like to put myself in the place of our resident. I would not like it if all of a sudden someone just starts, doing my hair without an explanation of what is going on. Introduce yourself to me. Let me know what you're doing with my hair. Be gentle with it. So it's important that we're very, very specific with our communication and we're able to show with them what we're doing before we do it. Give simple one-step instructions. Allow the person to complete one step before introducing the next step. Provide choices when possible, but not too many choices to become overwhelming. So it goes back to our principle of harmony and making sure that we find the right balance of everything that we do for our residents. And when it becomes challenging, try distraction with the snack. That has been something that we found a lot of success in as well. But communication is, and part of our normalization is as well, is treating them the way we would treat anyone. If you would not just grab someone by their arm and take them to a different room without an explanation, we would not do that to our resident or someone with a cognitive impairment. It is imperative that we also demonstrate through our words what we're doing, when we're doing, and why we're doing it in as simple way as we can. But it's important that we do that. It's important that we communicate as much as possible. Our next slide talks about presuming discomfort. Pain is often invisible in dementia. The person or our resident may not be able to say, hey, I'm in pain. I have a headache, my knee hurts, but might groan in discomfort, might slap their arm, which is hurting, or resist care. So we always have to presume discomfort first. And more than 20 years of regulatory and professional advice have shown that pain can trigger behavioral expressions. And unfortunately, due to the changes in the brain that occur for Alzheimer's disease related to language and perception, it is very challenging to identify if the person is experiencing pain and discomfort. So it's important for us to, again, be curious, to presume that they're uncomfortable and not just associate any behavioral expression with the sign of dementia, but truly rule out other factors, whether it's medical, whether it's environmental, whether it's over understimulation, before we go straight to, oh, this is just what they do. This is just who he is. This is just who she is.
Do exercises?
I'm so sorry. Can you repeat that, please?
Sure. Uh-oh. I said something. I hope it's interrupted.
Okay. So yes, that goes toward presuming discomfort. Our next slide talks about, Silverado Brea, and it goes over something that I wanted to share with you. So earlier I had shared about the charcuterie board, but the Nexus art, that is one of the things that we take a lot of pride in. So our residents, we have artists in all of our communities, and artists who were always artists, or artists who they discovered they were artists when they moved in. And it's important for us to validate and reinforce what they find purpose and what they find joy in. And to do that, we were walking past our residents' art one day and we realized these should be in museums, these should be sold, and we did exactly that. We had a Nexus Art Night, our gala. We had a red carpet. We invited all of our families, professionals, and we displayed all of our resident art. So everything you see on the screen was something our residents made. And we were able to sell out of every single art piece. We had a bidding contest for it. And all the proceedings went to Alzheimer's of OC. And it was such a beautiful thing to see our residents welcoming our guests and taking them to the art they had made, talking about it. It was very validating. It showed the importance of engagements that we do and the purpose we instill in our residents. And at Silverado, our approach is different. We meet each resident with empathy and evidence-based care, seeking to understand the why behind the behaviors. And we don't define people by their diagnosis. We look deeper. And when you look deeper, this is the result that comes out of it. If we have some time, I will like to share a story or two about what we have noticed in our residents. And if we go on to the next slide, this is actually one of the proudest moments I have had as a leader at Silverado Brea community, where a resident who wasn't successful at a hospital setting was brought into our community because of what they had heard, and had strongly recommended us. And from the moment that the resident stepped foot after not being successful in 3 other communities before us, she just thrived, and she thrived because of all the curiosity, because of all the questions that we had. When she moved in, she was throwing everything that she could find. She was vocalizing a lot, but not vocalizing discomfort. So it was a lot of investigation that we had to do. And 2 weeks after she moved in, she was painting, she was speaking with her family, and the sigh of relief that they had was what reminded us of what we do and the Silverado difference and how we show up. We hold space, and how we offer more than care, and we offer peace for both our residents and our families. So it's definitely a Silverado difference that we have noticed. And there's so many countless stories like that, why being curious and why investigating and doing our research and utilizing these evidence-based studies have proven to change lives for the better for our residents. If we go on to the next slide, there's another story of a very famous artist from New York who was very unsuccessful at another setting. She was declothing everywhere in the community. She was running away constantly, and she was bored, but we were not able to identify at the other setting that she was bored. So when she came into the community, we sat down with her. We were able to gather as much information from her family as possible. Our caregivers told us stories that she shared with them. Our housekeepers, our nurses, we all worked collectively as a team to gather as much information and realized that her love for art is what she missed. We realized she had a storage bin about 1.5 miles away from our community, and we drove and opened it and got all the art books and arts that she liked and completely redecorated her room. And now she finds so much joy in recommending those books to others and enjoys being part of outings. She's made friends that she talks to about art with. So it's important that we don't take that behavioral expression as, oh, this is who this person is, but truly realize what is going on. They're an individual. They bring a legacy with them, and it's important that we treat that legacy like we would treat our own loved one. So this is very important, and that's another story. And I can be here for 10 hours or longer just talking about the amazing successes that we have seen. I get goosebumps thinking about the residents that have moved in that were just did a complete 180. And it's because we were curious, and we didn't leave any stone unturned in providing them the care that we all want to provide them. Yes, and if we go on to the next slide, this is a message from me that I wanted to do, and I know that everyone at Silverado feels the same way. So this is truly a message from all of Silverado, that at Silverado, we're not just a facility, we're a home, a community, and a circle of care. We walk alongside families through some of the life's most emotional moments, and we care for those living with dementia and cognitive impairment with the same love, patience, and dignity we would offer our own. This isn't just our job, it's our purpose. So thank you so much. And Kim, unless you had something to add, thank you guys for listening and listening to our stories.
I don't. We're happy to take any questions or follow up.
Absolutely.
Yeah.
I do. I have a question. You mentioned that your receptionist had been dementia certified.
Mm-hmm.
Do you offer that certification to individuals other than employees?
Unfortunately, we do not.
We do not. We have an Alzheimer's Disease International actually accredited our education and training program 3 years ago, and we are the first U.S. entity to actually have that accreditation. So we had developed it about 6 years ago and their global review panel came and monitored our communities to see if we really were using what we learned. So anyway, unfortunately, we don't offer our training, but I would say, I know for a fact, and I'm sure Lauren can answer, that the essentials and the training that the Alzheimer's Association does is spectacular, and they have their own accreditation program too. So,
Oh, thank you. I'm new to this journey. My mom was just recently diagnosed. We've been seeing signs for about 8 years, but I work with special needs children, and I'm in the speech and language. So when you're talking about the ABCs and acknowledging emotions, I'm like, wow, I need to literally apply what I do every day to my own mother, which thanks to you guys, I never looked at it that way. So thank you.
That's well
I
said.
have
And
a
I just
question.
have to add, it's so funny. At least you come with the experience, because in 20 years of being a GNP in neurodegenerative diseases, the struggle with a family member is you don't see it as they're any different, and you just can't get your head around that these techniques that work for someone that you've described work. And so people continue to try to force reality, and really it's a big point of frustration, especially between spouses and children, that you're convinced if they tried harder it could do it. So well done for being able to see that you've got a great wealth of experience that should serve you well in your journey.
I really appreciate this, ladies. This is my first contact, basically, to start informing myself and seeing how to proceed, because I also have my dad right beside her that's starting to show signs as well. So it's going to be a long journey, but I want to thank you both for all your time and the information, because it definitely, I benefited from it today, and I'm so glad I was a part of it.
I have a question.
Yes.
Yes.
Can I ask a question?
Yes, you can ask a question, and thank you, Tanya.
Sure.
Okay, I have a boyfriend in a retirement home that every time I visit him, he says, "Why did we split up? Why can't you stay? Why can't you stay here with me?" What do I tell him?
Ashley, or I'm happy. I'll jump in first and then correct me if you'd want. But I would say, so we would always ask ourselves, what is the feeling behind that? Is he lonely? Is he bored? What part of your relationship does he miss? And so, to Ashi's earlier point, that need to validate that, like, I miss you too, and I have to live over here, but I'm here for the next hour, so let's enjoy it, and let's go, have a meal together, or have a snack, or let's walk outside. So it's always the first easiest level. But if he's got a little dementia, right, he's going to have rapid forgetting, so it's going to come up often, which just means always thinking, I'm going to validate what he's missing, what he wants from me. Is he missing talking to you? Like, oh, I'm here now, I look forward, let's talk, and then once you've validated that, slowly redirecting to what you're going to be able to do over the next, 45 minutes or the time of your visit. So it is very tough. And especially that's what is hard for spouses and children and friends, because the difficulty in understanding the why. So you just have to really respond to the emotion. Anything you would add to that, Ashi?
No, I think you summarized it really well. I mean, I would just, and I'm sorry if I'm mispronouncing your name, Zori, I would just try to get as validating as I possibly could. And like Kim mentioned, redirect him to something he enjoys doing, making sure that he feels belonging at where he is currently. If he is actively engaged, is he able to socialize well? It's important that he is connected there for him to find success. So making sure that he is appropriately engaged is definitely the next step that I would work on with him.
He is 96 years old, and he is constantly telling me, "Why did we split up? Why did we split up? Why can't you stay?"
Yeah. No, it's an
I should
unfortunate.
go to a retirement home, and I don't know whether I should join him or whether I should go to another retirement home.
Well, that depends, of course, on what's good for you. Absolutely. And I will just tell you that from my perspective, don't get caught up in the what he's really asking in a way, right? Because this is kind of where we'll have residents or someone will say, I want to go home, I want to go home. And then family works very hard to try to get them home to where they think is home. And this person will say, that's not my home. They're thinking of home from 50 years ago, not where they lived the last 10 years of their life. And so that's where, you know, you can not make yourself crazy, that's poorly said, but I mean, you can kind of really try to fix what they're asking in words when the best response is actually the feeling. As you know, I'd like to be with you now too. We had a wonderful time early in life. I have photos. Let's look at what we, you know, or whatever, redirecting and then, you know, validating that feeling of I'd love to be with you here too right now, but I'm here now. So let's, you know, wasn't that great about 40 years ago or whatever, right? That we had. So that's the way we would validate and redirect, because and I think what Ashi has said is really important about, you know, is he connected to folks there? You know, sometimes
He
that's
likes it there. He
Okay.
likes it very much. He said people here are very nice.
Okay, well, that's a win then. That's good. So then validating and acknowledging you'd love the time when you guys were girlfriend, boyfriend, and let's enjoy the moment now is how we would redirect him.
Thank you.
Well, this is Colleen Freeman. I just had a quick question. You mentioned my mother-in-law, she just got diagnosed with moderate to severe dementia. And she, you know, you talked a little bit about caring for themselves, taking a shower, brushing your teeth. You made a comment about just, you know, giving them a treat or what have you. Do you guys have anything available that we can access for other techniques? Because she literally will not take a shower. She's just adamant. Tried to acknowledge why she doesn't want to take it. It makes her, she feels weak and it's cold and that type of thing. But do you have any other information that we could grab for other techniques to try to care for her in that way? It's been very difficult.
Yeah, I can help answer that. And we see that a lot, Colleen. And one of the reasons is not only is there a lot of steps that an individual or a resident has to take or a loved one has to take when they're going into the shower, which seems very overcomplicated to someone with a cognitive impairment. It also comes down to dignity, right? A lot of them value, you know, someone not helping them take a shower. They've been doing it independently for such a long period of time. And we have seen struggles, especially when they initially move in and being able to take them to do their ADLs, to take those showers and to clean themselves. And what has worked for us is, first of all, explaining what we're doing and why we need to do it. That has always worked for my favor, explaining, hey, Miss Smith, I need you to go to the restroom, or I need you to take a shower. It's been, you know, a few days, and taking them there and helping them do as many things they can do independently as safely as much as possible. So if it's possible for you to be outside the restroom when she changes, if she enjoys listening to certain music, that can be very helpful as well. Or telling her something she might enjoy doing after it. So, hey, once you are done with your shower, let's go out and get something to eat, or let's get something to drink afterwards. So making the experience as nice as she can as possibly you can make it. I think that's a win as well, because she should enjoy wanting to do it. It shouldn't come across as punitive or as a punishment for her. And you can, again, individualize it as much as possible with her favorite music, with maybe TV that she enjoys playing in the background, and giving her an engagement that she can do afterwards to, you know, make it a good experience for her.
I would also add in our spa rooms, right? We have we always have it warm because nobody wants a cold shower. And what also in addition can work is giving someone some control, right? For a lot of people, you know, with no explanation, people can be being pushed into a shower. They don't understand completely what's going on. And it's like, why would I undress with someone I don't recognize? And all of those kinds of things can get very complex. So, you know, if you have a handheld shower as an example, you know, give her that. Our caregivers often will hand a resident the washcloth and let them wash themselves. That's that autonomy that Ashi described that is so important. So thinking about those kinds of techniques, and we often do see that people love when it's we're going to shower and then we're doing this. And it's got to be fun. So to her point, we're going to shower and do something. We're going to shower and go for an ice cream. We're going to shower and go for donuts or whatever. That works excellently too. Yep.
Hey, thank you. I appreciate it.
Mhm.
I think Callie, you had a great point as well. Callie added that she makes showering like a spa day. So they run the water, they get the bathroom warm and turn it into a spa. So that definitely sounds very enjoyable and very nice.
You know, and I think too, Ashi, something we do, we find that our caregivers will often use our beauty salon to groom our residents. So that, you know, because part of what Ashi referred to at Silverado, our normalization, which means that a person living with dementia is treated just like someone with the same dignity and respect you would have for someone without dementia. And, you know, and people don't always love some caregiver or somebody else brushing their, you know, hair in the room fast on the way somewhere. But if we take them down to the beauty salon and do their nails and do the grooming and put on their makeup there and actually, you know, set their hair or use the curling iron, people, you know, it's similar to in the old days, they used to think someone living with a dementia had to have all paper cups when they drank because they, you know, throw them. We know that now, and there's good research behind it, right? That if you give an elegant dining room with flowers on the table, with regular forks and knives and glasses, that people, that's years and years of learning how to act appropriately in a nice dining room. And you don't end up with behavioral expressions. And it's similar around grooming. So the idea, like you mentioned, in terms of, hey, we turn it into a spa day and it's a really fun day. And who knows, maybe we have a glass of wine or make it the whole deal. I think that's brilliant. Yeah.
Yeah, I think the problem with her is she just has no interest in caring for herself anymore, grooming herself. She doesn't care. She's tired, you know what I mean? So I think there's kind of a little bit more to it that we have to build upon to get to that point, like what you're talking about.
And for sure, if you're talking health and fatigue from something else, but I will also say, remember that in dementia, one of the symptoms that occur, we see that forgetfulness, but you know, that executive dysfunction that can occur, which is really your get up and go and your, you know, your desire, your initiative. And that front part of your brain, that's often affected. And so it can just be kind of like apathetic. I'm not really interested. And then the final thing I would always add for you to talk to your provider about is, remember, between 30 and 40% of people with early dementia, Alzheimer's disease, have a concomitant depression that does usually respond to non-pharmacological treatment and, if necessary, pharmacological treatment.
Okay, thank you. That's helpful.
All right, well, we may be passing it back to Lauren.
Yes.
Any other questions? Nothing in the chat we had to answer, right?
Well, I have another question. What if I am wanting to downsize and move to a retirement home and I don't care anymore? I don't dress up like I used to. I have a lot of clothes that I don't wear. I just wear the same thing over and over again.
Well, I'm not going to diagnose you, but I'm for sure going to mention, you know, we know post-COVID that social isolation is huge in terms of progressing, you know, making people more depressed. It actually can make you look like you've got some cognitive impairment because social isolation is such a determinant of overall health. So I would speak for myself that I would be for you being around where it's easier to be around other people, especially if you're finding it, I don't really care to on my own. In fact, we often talk about, don't we see, Ashi, in our communities, people that may be in an isolated apartment where everybody thought it was a great idea to put them in a long hallway in an assisted living setting. And when they come to our communities, we describe that at Silverado, for most of our residents, we encourage their bedroom doors to be open. They get drawn out. Then, even if they're not in the mood to do anything, they get drawn out by the music, or the dog walks in and draws them out so that they're not isolated, because isolation is such a negative predictor of overall health.
Totally. And we're social beings. So the more we're around, you know, the society, that is inherently what we desire, whether we like an engagement or not, but not maybe participating in it, but sitting next to it. So you're next to your peers, you're next to your friends. That makes a lot of difference as well. So yes, I definitely agree with Kim's point on that.
My name's Jordan. I can speak to this real quick because my mom has been in a care facility near you for the last 18 months or so. And we moved her into a 2-bedroom thinking that when we come to visit, we could stay with her. And it seemed like a good idea at the beginning, but it turned into not a good idea because we were interrupting her routine. So it was good for like 2 days, but after 3 or 4 days, it got annoying for her. So we moved her into a 1-bedroom, and this point you're talking about now is why we moved her into the less independent, into one of the secure environments, so she would not isolate. When she was by herself in a 1-bedroom, it's everything you ladies just said. Is that I noticed she was isolating, and even phone calls wouldn't um, get her through it. But she would forget that she saw people. But some of the caregivers there said that when they brought her food, she would kick them out and place the food in the hall.
I have to say, congratulations for pivoting, because what we'll often see is family members think, in your 40s, you may want to be left alone by other people. You may think that, isolation is a good thing, but you're right, not always, and not when someone's living with a neurodegenerative disease.
No, and I've been following you guys for a while. When I'm in Southern California, I go to a support group, and it's run by a fellow whose name I can't remember. He looks like William H. Macy, but he ran a Silverado.
Yeah, Vic.
Yeah, Vic, is that his name?
Vic
Yes.
Mez. Yeah.
Yeah, so he's like, and everything you guys say has come to fruition. It's
unfortunate.
It's fascinating, so it's very good.
Thank you.
Ladies,
I could get my brother to listen to you guys. That would be a heavy lift, but it would be good.
Ladies, I just have one last quick question, just because I don't know whether this is related to dementia, if I should take my mom to the doctor on another matter. Her appetite is basically disappeared and her emotions have heightened from an 8 to probably a 12. Is that common, or could this be related to something else because she is so upset about her diagnosis?
I'm going to answer just because I'm the nurse on the phone, but I will say that I would absolutely have it looked at for sure.
Okay.
But what always comes to my mind, nobody started her on a medication like Aricept, did they?
She just about 6 weeks ago, they put her on something, but I'm not sure what it is.
So I will say there's a medication that's used to help with, it can cause some modest improvement in ability to think a bit and some recall. And so some people do better on it. Not everyone does. But one of the side effects of those drugs, they're called cholinesterase inhibitors, and they're Aricept or donepezil, Razidine, Exelon, or galantamine, and all those medicines actually reduce appetite. And what can often happen is people get started on them when they get a dementia diagnosis and nobody realizes that. And then all of a sudden doctors and providers are instead of stopping that, they're adding medicines to increase appetite. So do have your physician look through her medications.
Okay, I will do that. Thank you.
Okay, what if as a caregiver you are unable to sleep?
Well, I'll tell the story about residents. I can tell you for sure about our residents. We often laugh because people will say, oh, she never sleeps. And then they come, and if you keep someone busy all day, so maybe your idea about the retirement center is great, because if you keep our residents really busy, which we do, we often hear, they're sleeping through the night. What's the problem?
Yes.
Because it's, for sure, that's a big deal. I will also say we did some research with a USC researcher on light in our communities, that he measured the light meters, how close. There's 2 studies I'm going to quote you. One is, it's well known that if you get outside light, so sunlight, direct sunlight, between 8 and 10 in the morning, that you sleep much better. And if you have any kind of cognitive impairment, there's a reduction in sundowning type behaviors. And then this recent researcher back in 2018 from USC named Kyle Konis published 3 articles about not if you can't get outside, how close you sit to a window with ambient light even can affect it. So light is a real benefit, sunlight especially for people that are having great non-pharmacological treatment for sleep disruption. That's about all I have on that one though.
Yes, and I know Kim, you mentioned it wonderfully, but as stimulated as you are, I mean, I think as individuals, right, it's so important having a purpose throughout the day. The more busy we are, waking up in the morning, going for a walk, going to work, our residents are the same way. They want to have physical exercise, socialize and have breakfast with their friends. The more social you are, the more engaged you are during the day, both with cognitive impairment or without. It helps you sleep better at night. It gives you a sense of purpose during the day and restfulness at night. So, yeah. Well,
All right.
Thank you.
thank you all. Thank you all
Thank
for
you.
attending
Appreciate
and
your
for
time.
answering questions. And Lauren, anything else if you want to chime in?
No, I just want to say to both of you, thank you so much. This was such a wonderful presentation with so much wonderful information. I know for me personally, the thing that stuck out the most was curiosity and not control. So I think that's just an important thing for us all to take away is we're there to help and figure out what's going on and not make that decision for them. So this session has been recorded. I can send out the link to anyone that may be interested. It'll be available on our YouTube page next week. And then as you exit, a survey will pop up. We ask that you please complete that. The feedback is invaluable. Lets us know what you want to see next and lets us know how we're doing. Other than that, thank you again, Kim and Ashi, and everybody have a great rest of your day.
Thank you,
Thank
everyone.
you.
Thank you for
Thank you
listening.
so much.